I'm the Director of Membership and Engagement at Suicide Prevention Australia, and it's my pleasure to welcome you today to this afternoon's Data in Practice webinar with the Australian Institute of Health and Welfare. Let me first stop and acknowledge the traditional owners of the land and the country in which we meet today and where each of you are joining us from. I'd like to pay my respects to elders past, present and emerging. I'm joining you today from Gadigal land of the Eora Nation. I'd encourage you all just to maybe pop in the chat where you are joining us from and as part of our acknowledgement. I would also like to acknowledge the voice of lived and living experience of suicide, recognising not only the suffering that suicide brings when it touches our lives, but the courage of those who do go on to share their stories and their experiences. And it's from this information that we can do better. You'll hear a lot of data today, and it's an important part of the storytelling, but it doesn't tell the whole story. We recognise that behind every statistic lays a person's life and a story and life of loss and distress, and obviously a cascade of grief amongst family, friends, schools, workplaces and communities. We will use this data to do better and to improve suicide prevention and save lives. So I am pleased to introduce you today to the second webinar of the series, Data in Practice, which is in collaboration with our colleagues at the Australian Institute of Health and Welfare. As the Director of Membership, I'm always eager to hear from our members around what they want to learn more about and the sorts of ways in which we can support them in doing so. One of the most common things we hear from our members is the importance and need for data. More of it, more timely and more often. This new series responds to that and continues our deep dive into the National Suicide and Self-Harm Monitoring System. This new national system is the most comprehensive collation of data for deaths by suicide, as well as self-harm and suicidal behaviours in Australia. It's designed to improve the quality and accessibility and timeliness of data on suicide and self-harm, and to support policymakers, researchers and practitioners to drive better outcomes in suicide prevention. At our last webinar, we looked at suicide mortality datasets. Today, we're going to shift our focus to attempts and self-harm data. And it couldn't be more timely with the data release by the Australian Institute of Health and Welfare today, and the significant release of the National Mental Health and Wellbeing Survey that came out last Friday. But before we get into the series and the webinar proper, let's just take a moment for some quick housekeeping. Please ask your questions in the question bar throughout the presentations, as there will be an opportunity for Q&A at the end of the session. Please remember always to use safe and respectful language in your questions, and to restrict these questions to topics and the presentations today. If you feel that your question is not being answered, please reach out to Suicide Prevention Australia and we will endeavour to answer your question. And finally, do take care of yourself today during today's webinar. Please reach out to a trusted friend, colleague, or one of the support numbers listed in the chat that will be available throughout the webinar should you need any support. Now, it's my great pleasure to introduce you to our speakers, Chris Gillick-Moran and Rosalind Morland. Chris Gillick-Moran is the Head of Suicide and Self-Harm Monitoring Unit at the Australian Institute of Health and Welfare. Chris has more than 20 years' experience in the development of health policy and evidence in the Australian and ACT governments. Chris's areas of specialisation include suicide prevention, mental health policy, alcohol and other drug policy, and the use of data and evidence to inform government decision-making. Chris holds a Bachelor of Arts with Honours from the Australian National University. Rosalind Morland is a Senior Data Scientist and Project Manager in the Suicide and Self-Harm Monitoring Unit within the Australian Institute of Health and Welfare. Rosalind has been working with the health sector since 2015 as an allied health professional before joining the AIHW in 2017. Ros's area of specialisation include biostatistics, epidemiology and public health. Ros holds a Bachelor of Human Nutrition and a Master of Nutrition and Dietetics from the University of Canberra, and is currently completing a Master of Public Health and a Master of Global Health at the University of New South Wales. I would now like to warmly welcome Chris and Ros to share their presentations. Chris, over to you.
So good afternoon, everybody, and thank you, Sarah, for that warm introduction. As I've popped in the thread, Ros and I are joining the conversation this afternoon from Ngunnawal country, and I'd like to pay my respects to their elders, past, present, and emerging. I'd also like to acknowledge those people in the conversation today who may have lived experience of suicide, either through bereavement or through surviving. And I'd just like to acknowledge what Sarah mentioned as well, that as we go through the data that we're going to be looking at today, it's important for us to remember that every data point represents an experience that someone has had and a great deal of distress that has occurred to the individuals and to the people around them and their communities. But it's only through examining these data and seeing what we can find that we can find the best evidence to improve our suicide prevention efforts. Now, I'm going to try and share my screen so you can see the slideshow. Before we start, though, I've just some people who were involved in the webinar earlier in the year looking at mortality data might find some of the introduction repetitive. I have included some of it in again because I'm sure there are people who have joined us today who were not able to join us earlier in the year, and for those of you who did attend earlier in the year, you might find the refresher useful, but if you've memorised it all, maybe you have some time to go and make a cup of tea before we get to the new material that we'll be discussing today, which is mainly focused on morbidity data, and morbidity data is looking at non-fatal suicidal behaviours. So the National Suicide and Self-Harm Monitoring System was established in 2019. It's hard to believe that all the work that Ros and I are going to show you today has been achieved in the last 3 years. And I'd really like to thank the Department of Health, one of our partnering agencies, for providing the funding for the website and other material that we'll be looking at today. I'd like to thank my colleagues at the National Mental Health Commission and the now newly established National Suicide Prevention Office for all of the support and sector engagement that they have done on behalf of the project. I would also just like to let people know that as of just earlier this month, we've been able to secure additional funding for the continuation of this work. So we're in contract now again for until the end of 2024-25. So I'm hoping that will provide some welcome news for people. So as I mentioned, today we'll be doing an introduction to morbidity data. Just a word on language. Morbidity is not necessarily data that's focusing on the morbid, as we might use that term in literature or somewhat. It's really looking at all data from all causes of external injury and disease that does not relate to a fatality. And in that sense, it looks at all hospital admissions, admitted patients' data. We've been able to start an ambulance data collection that we'll look at today as well. And I suppose theoretically, you might use it to refer to other community services where people are being treated for diseases or external causes of injury that do not result in a fatality. So I'm going to start with some key concepts and definitions of the data sets that we'll be looking at today. We'll be looking at the sources of the morbidity data that we'll be discussing, looking at strengths and weaknesses, or sorry, not weaknesses, limitations of the data, and giving you an introduction to some of the key morbidity collections that we feature in the National Suicide and Self-Harm Monitoring System. Now, I know a lot of people get concerned about data. Some people find it a little bit confronting, but there'll be nothing we discuss today that you won't be able to understand if you have some basic assumed knowledge of addition, subtraction, multiplication, and division. And I think I made a comment earlier in the year that you might need to break out a square root or something, but I don't think we'll even need to do that today. So please, if mathematics is not your strong suit, don't be anxious. So the first key concept that I want to introduce people to or remind people of is the World Health Organization International Statistical Classification of Diseases and Related Health Problems, 10th edition, Australian modification. We often shorten that to ICD-10. So when we say ICD-10, it's because we don't want to spell out that very long World Health Organization title. We're looking at two key components of the ICD-10 today. The intentional self-harm codes, as I've put on the slide there, run from X60 to X84. And the codes that are within that bank of codes generally look at intentional self-harm distinguished by various methods or mechanisms of self-harm. And by that I mean, perhaps hanging or cutting with a sharp object. We also include the sequela of intentional self-harm, assault and events of undetermined intent, Y87. Almost all of the Y87 codes relate to intentional self-harm, and sequela is a subsequent complication of earlier treatment that ends up being fatal, but is not the result of the self-injury in the first instance. Because we're also looking at some ambulance data that's not looking strictly at intentional self-harm, but other surrounding behaviours, we'll also have a need to look at some of the accidental poisonings by and exposure to noxious substances, which is really a way of looking at acute intoxication as well as overdoses. It doesn't include diseases secondary to the use of alcohol or other drugs, for example, liver disease or lung cancer in the case of tobacco exposure. And then we have events of undetermined intent, and I can assure you that they're very marginal, so I've just included those there for completeness. A note on intent, and I'm not here talking about a psychological note on intent, because I know that's a different story about people's ability to formulate an intent for their actions to have some specific outcome, including in intentional self-harm. But here I just want to draw people's attention to the fact that the ICD-10 is able to code distinctions in the intent of an act, as in the act was intentionally done, the act was accidental, or the people investigating the act were not able to determine the intent. What the ICD-10 cannot distinguish is the intended outcome of the action. And the distinction here is very important for hospital morbidity data. We cannot determine if someone intentionally harms themselves with a view to dying by suicide, or if somebody intentionally harms themselves for some non-suicidal purpose, for example, the alleviation of psychological distress or some other reason. It will become clear over the presentation about some of the limitations that those definitions have on what we can determine is in the data. Oh, sorry, well, there we go. This has implications for interpreting mortality and morbidity data, and we'll tease some of that out for you. So we're looking at two key collections here today. First of all, we'll be looking at the National Hospital Morbidity Database. This is published annually, about 9 months after the end of the reference period, which is by fiscal year. if people cast their mind back to the mortality data presentation earlier in the year, those data are published by calendar year. And so automatically we have a little bit of a misalignment of where we can actually interpret data alongside each other. So we do need to keep that in mind when comparing patterns of mortality to patterns of morbidity as we're actually looking at overlapping time periods. These data are compiled by the state and territory health authorities and collected here in the AIHW for national publication. All of the data that we received is confidentialised, and importantly, what we count in morbidity data is separations. A separation, it can be a discharge from hospital, it can be a transfer from one part of the hospital system to another. And so just keep in mind that one person during a single episode of care may accrue more than one separation, particularly if their case is quite complicated and they need to move from perhaps ICU to admitted patients or that kind of thing. So what we're really not talking about here is people. And when we were looking at mortality data, we were definitely counting people. Here we're counting hospital separations. And of course, a person may go to hospital more than one time during the counting period for an event that we're interested in recording here. So it's an important distinction. The other thing we'll be looking at today, or the other collection we'll be looking at, is the National Ambulance Surveillance System. We're pretty proud of this part of the system. Well, we're proud on behalf of our colleagues at Turning Point at Monash University who have established this system. Importantly, this part of our data collection does not use ICD-10. This uses a bespoke coding classification that Monash University have developed over the last 15 plus years, where they've been evolving this system. And it is globally unique. We do know that people look at ambulance data in other parts of the world, particularly around some research agendas, or in some places they might look at a sentinel area, and I do know that there is some examples of that run in parallel to the NASS in Australia, particularly around ED data. But nowhere else in the world collects this data as systematically and as for such a large proportion of the national population as we do here. That said, we don't have national coverage as yet. We do have coverage from New South Wales, Victoria, Queensland, Tasmania, and the ACT. And besides counting attendances for events that may be of primary interest to people here today, that's looking at suicidal ideation, attempted suicides, suicide deaths, and non-suicidal self-harm. We also collect information through the NAS on symptomatology of mental ill health and acute intoxication or overdose by alcohol and or illicit drugs. Now, just one thing to note here, we do count suicide deaths in our data. We don't publish that. A question that we do get often is, why would an ambulance be called when a person had died by suicide? And we think from investigating these data that the vast majority of those cases are where an ambulance is being called to a person who has has harmed themselves deliberately, and they die while the ambulance is in transport to get them. We do collect a lot of other interesting things that we have yet been able to analyse fully and therefore haven't published. And some of these include the proportion of people who are transported to hospital following an ambulance attendance for a self-harm event. We will in time get to those, because a lot of these things do have implications for how we might advise hospital administrators or suicide prevention people, employers, about how they might go about their business. I can let you know that the vast majority of attempted suicides do get transported to hospital, well over 90%. Also, just keep in mind that probably not so much for the hospital's data, but definitely for the ambulance data, a lot of things that might look like differences in behaviours at the population level actually reflect treatment protocols that the ambulance personnel need to follow. So if there's a big difference between two jurisdictions, it's worth investigating whether there's a difference in what kind of events ambulances get called to, as opposed to what kind of events some other kind of support might be called out for. And an example of that in the ACT is the TRI service attendance through the police, ambulance and clinician emergency response. Although I do think that does get caught up, does get captured in our ambulance data, but we're just not 100% sure. So just keep that in mind as well. And to give you some indication of the interactions between all of these types of ambulance presentations, I've just got an example here. This is from December 2021, January of that year, actually, looking at the intersection of alcohol and other drugs, mental health attendances, self-harm and interpersonal violence. And as you can see, it's very, very difficult to disentangle any one of these types of behaviours or these types of ambulance attendances from one another. And this would come as no surprise to any of you who have worked in suicide prevention or indeed AOD or mental health, or worked with victims of interpersonal violence. We know that the risk factors for these being a victim of these types of behaviours, or indeed where we're looking at interpersonal violence perpetrator of these types of behaviours, are very closely intertwined. So I would caution against viewing any of these things in complete isolation. Now, at this stage, I'm going to hand over to my colleague, Roz, who's going to start taking you guys through the data. But just as we got some really good feedback on Roz's explanation earlier in the year on age standardised rates, we thought we might give you all a little statistical treat at the beginning of this presentation and talk you through a distinct concept that sometimes sounds like it might be the same sort of thing, but it's different. And we'll be looking at some of these data today. So this is on age-specific rates. So Roz, please.
Thank you, Chris. I'm going to swap the seats. Great, thanks, Chris. That was a great introduction. So as Chris mentioned in the previous seminar, we explored the concept of age standardized rates, which are hypothetical rates that would have been observed if the populations being studied had the same age distribution as the standard population, while all other factors remained unchanged. In this seminar, though, I wanted to give you an example of age-specific rates, which, unlike age standardized rates, are looking at the effect of different age structures in a population. And the majority of the visualizations we're going to look at today also use age-specific rates. So to explain this, I'll give an example. Okay, so there were 1,331 intentional self-harm hospitalizations among males aged 15 to 19 years in between 2020 and 2021. In the same year, there were 1,463 intentional self-harm hospitalizations among males aged 20 to 24 years. So we can say that there were more hospitalizations in the 20 to 24 age group overall. But looking at the numbers alone doesn't tell us which age group, so it doesn't tell us which age group had more hospitalizations proportional to the number of people in that age group. So when we're comparing these two age groups on numbers alone, we're just comparing apples to oranges. So age-specific rates are calculated in the same way as crude rates, except that both the number of suicide deaths and the denominator population are restricted to a given age group. Okay, so bringing it back to our example, use the age-specific rate of intentional self-harm hospitalizations among males in 2021 was 173.5 per 100,000 population in the 15 to 19 age group, and 166.3 per 100,000 population in the 20 to 24 age group. So despite the 20 to 24 age group having a larger number of hospitalizations, the age-specific rate is actually higher in the 15 to 19 age group. And this is because the denominator population for the 15 to 19 age group is smaller than the 20 to 24-year-olds. So hospitalizations are proportionally higher in that 15 to 19 age group. So now we're comparing apples to apples. So that was just a super quick overview of age standardized rates. And now I'm going to jump into giving you a quick introduction to the two data sources on our website that we're looking at today, which is ambulance attendances and intentional self-harm hospitalizations. Chris already gave a bit of a rundown, so I'm not going to repeat any information. But just a quick note that our self-harm related ambulance attendances includes attendances coded as self-injury, suicide, suicidal ideation, suicide attempt, and suicide. But just note that suicide, suicide attempt, and suicidal ideation are considered mutually exclusive, but self-injury could be simultaneously coded with any of the other self-harm categories. And also note, as Chris mentioned, the number of attendances related to suicide is underrepresented as ambulances don't attend all deaths. And when they do attend, there may be insufficient information to determine suicidal intent at the scene. And as Chris mentioned, we don't report this. Okay, those are my backup slides. So now I'm going to jump straight into the website and we're going to have a look. Bear with me while I just bring the website up. All right. I believe everyone can see my screen. Yep, everyone can. Great. Okay, so I'm just going to start off with ambulance attendances first. So this first section of the website, of the ambulance page, it just gives us a bit of an overview of ambulance attendances for the year. And this is for aggregated quarterly snapshot months in New South Wales, Victoria, Queensland, Tasmania, and the ACT. This section is currently just for 2020, but we should be able to update to 2021 in a few months' time once the remainder of the 2021 data supply is supplied to us. So I'll just scroll down to the first viz. Here we go. So this first visualization is just a bit of an overview of the differences between sexes within the self-harm behaviours for 2020. So these are aggregated quarterly snapshots. We can see down the bottom there, they're for March, June, September, and December. It gives us the crude rate, which, as I mentioned before, it's similar to the age-specific rates calculated in a very similar way, but this time we're not disaggregating by age. And we can select all the different jurisdictions down here as well. So the rate of attendances across these categories, in most jurisdictions, the rate is higher among females. The exception being suicidal ideation in New South Wales and in Tasmania as well. If I just swap to Tasmania, there we go. It's a little bit, males are, that's still New South Wales. Males are a little bit, just a little bit higher. But for all the other jurisdictions, females have higher rates in all these categories. So I'm going to keep moving. So now let's break that down a little bit more. Keep in mind, we're still just looking at 2020 here. So this viz gives us a bit more of a breakdown now by sex and age group, by suicidal behaviour. And we can see that a lot of those higher rates in females that we saw in the earlier viz are being driven by these higher rates in the younger female age groups. So males tend to have higher age-specific rates around the middle ages, so around these age groups here, but that just doesn't compare to the higher rates we're seeing in the younger female groups. we'll see in the hospital section a similar story among females with intentional self-harm hospitalizations as well. Just going to keep scrolling down to the next visualization. Okay, so now from this section onwards, we start getting into our time series visualizations, which gives us an idea of attendances over time. So I'm just going to start by looking at New South Wales. So I just wanted to note, in New South Wales, you can see there's a break in the data series in June 2021. So it looks like there's a big steep drop between March and September for ideation, but because we're missing that break in the data series, we don't really know what happened in between. And we can also see historically that there was some drops around June and September as well. So there could be some seasonal effects there. But overall, there was a steady upwards trend for ideation, while self-injury and attempts were fairly steady with a slight increase. I'm just going to hop over to Tasmania now. So contrast to New South Wales, you can see that the rates for Tasmania, they tend to jump around a bit. I'm also going to switch on the error bars, because the error bars here, these are our 95% confidence intervals. And you can see for Tasmania, they're quite wide. So it's quite useful to turn these on when looking at the smaller jurisdictions, because if these error bars cross, so for example, September compared to December, we can see those error bars are between 14 and 21.3, and then we got 16.7 and 24.5. They're actually crossing each other. And when we're calculating rates, we're estimating, it's an estimate. So what we're saying is that the true rate lies somewhere in between that 95% confidence interval. So when they overlap, it's not really a significant difference, even if it looks larger or smaller, because those 95% confidence intervals are overlapping. So that true rate is somewhere within those ranges. So we'd be looking for differences where those bars don't overlap. That's just something to keep in mind. And when looking at these smaller jurisdictions like Tasmania and ACT, the other thing to keep in mind is that because it's a smaller population, you see more insignificant changes, if they're more obvious. So for example, if you had one attendance 1 month and then 2 the next, in this time series, it would look like it's doubled. But in reality, it's only 1 extra attendance. So you just need to interpret these things with caution when looking at smaller numbers. So yeah, for example, like we're looking here at Tasmania. If we look at December compared to December, those bars they're pretty close. So you just got to keep that in mind when you're looking at the smaller jurisdictions. So I'm going to keep scrolling. Okay, so the viz underneath, at first glance, it probably looks much the same, and you are correct. The difference is this viz, we're looking at the quarterly snapshots. We've got March, June, September, December. But from the beginning of 2021, we started receiving monthly snapshots instead. But we only had that from 2021 onwards. So we've just included the monthly data here, but over time, as this time series gets longer, in reality, it'll probably overtake our quarterly snapshots. So it just gives us a little bit more understanding of what's happening between these quarters. Sometimes where there's a big jump, and particularly if you're looking at 2021, you'll be able to see, well, what's happening between those snapshot quarters. So I'll keep moving. So the next viz we have is patterns by gender over time. So through most of these behaviours, similar to what we saw in the previous visualizations, females tend to have higher rates over time. For most of these behaviours, we can see that the purple line representing females tends to be higher than males, except for suicidal ideation here in Victoria, where they're a little bit closer. One I wanted to point out, though, was in ACT. Again, we're going to interpret everything here with caution. We can see there's a bit of a jump in the females, but I'd like to draw your attention to those error bars as well, which you can see are quite wide. So again, we just need to question everything we're looking at and interpret with caution. And again, this visualization here is the monthly snapshot version of the one we just saw before, which is the quarterly, which just sometimes, like again, when we see these big jumps, those jumps aren't so large when you look at the monthly, month to month. Okay, so this is patterns by age and gender over time. And this is actually my favorite viz on this webpage because it breaks down things just a little bit further. We're looking at age, we're looking at sex, and we're looking at snapshot months. But you'll notice that the jurisdictions are aggregated because otherwise the numbers would be way too small, particularly for ACT and Tasmania. And that just sometimes happens. You'll notice throughout the vizzes, we have to get creative in how we aggregate in different ways so that we don't lose data to suppression. So this one's quite interesting. For self-injury, the age groups are a little bit larger because of small numbers. So we've got 0 to 24, 25 to 44, and 45 plus. But if we hop over to one of the other behaviours, we get a few more age groups. So we get one extra one, the 65 plus age group. We can see for self-injury, if I jump back to self-injury, there's there's quite a large gap between the 0 to 24 age group and the other age groups. And that's something that we're seeing consistently in the intentional self-harm hospitalizations as well, where for quite some time, intentional self-harm hospitalizations among younger females have been trending upwards. So the last viz that we have on this page, which I'm not going to show you today because it's just a bit confronting, but it's looking at the methods behind self-harming behaviours. If you feel comfortable, please feel free to have a look in your own time, but just know that it's aggregated to 6 months so we don't run into those small numbers, and it's aggregated to all jurisdictions. And because of that, it doesn't yet include 2021 data, because we were missing 2021 data for June, and we hadn't received the complete data supply for December 2021 yet from New South Wales. So it would, because it's aggregated by jurisdiction, it would mess up all the proportions. So at the moment, that viz is just 2020. If you feel comfortable, please go have a look in your own time. Okay, I'm moving on to intentional self-harm hospitalizations now. Okay, so the first visualization we're looking at for intentional self-harm hospitalizations is we're looking at a breakdown by state and territories. And just as an overview, there were more than 29,900 hospitalizations due to intentional self-harm in the 2020 to 2021 financial year. The highest proportion out of the total number of these hospitalizations was in Queensland at 31.7%. But the highest age-specific rate was in the Northern Territory, this one here. So remember the difference when looking at number versus rate. Northern Territory has a small, the Northern Territory has a smaller population than Queensland. So the proportion of people with hospitalizations is higher in Northern Territory, why Queensland had the highest number of hospitalizations overall. It's just an important distinction to make. New South Wales, followed by Victoria, had the lowest rate of intentional self-harm hospitalizations. And we can see a bit of an increasing trend here in Northern Territory and Queensland as well. So just another thing to note, I'm just going to swap to females here. For those who came to the last seminar when we were looking at mortality data, or we're looking at deaths by suicide, you would recall suicide deaths were consistently higher in males compared to females. For intentional self-harm hospitalizations, we see the opposite. Females consistently have higher intentional self-harm hospitalizations than males. And this may be due to the differences between suicide methods used by males and females, with males tending to use more lethal methods than females. So yeah, if you were to flip between, keeping an eye on the y-axis here between females and males, you could just see that their rates are quite a bit higher. As I was mentioning before, you always really need to question the data every time you look at it. And consider the limitations. So there were some decreases in Victoria in 2011 to 12 and 2012 to 13. And this may in part be due to changes to Victoria's emergency department admission policy. So we have a data quality statement. Always give that a read when you're looking at this data. So the next one is age groups. This is a really cool visualization. It's just a further breakdown of age groups. In that previous visualization, we didn't get the age groups, but this time we do. A big obvious standout is the young females here, particularly the 15 to 19 age group. And if I hover over that bar, you get a little sample of the trend over time, which is pretty cool. There's an interesting story going on with the age-specific rate for females aged 0 to 14. As we can see, there's been a bit of a jump in the past 12 months. You can see it on the trend there. So the age-specific rate for 2020 to 2021 was 70.5. And if I just jump back a year by using the slider, it was 40.5 a year ago. So there has been a bit of a jump in that age group. Sorry, this is in the way. I'll get rid of that. Oh, okay. Yeah, thank you. Thank you. Just struggling with technology. Don't mind me. Right. Well, geez, that content warning should be up. This is another visualization looking at the method of intentional self-harm. I know you just got a quick glimpse there, but I didn't want to go into too much detail in this one today. Again, it's a little bit confronting, but if you feel comfortable, just please go through it in your own time. But I will highlight some key findings. So the most common method for intentional self-harm hospitalizations was intentional self-poisoning by anti-epileptic, sedative, hypnotic, anti-Parkinsonism, psychotropic drugs. And that was for about 40% of hospitalizations for intentional self-harm in 2020 to 2021. And in that group, there were about 8,000 females compared to about 3,800 males. The next common method was self-poisoning by non-opioid analgesics, antipyretics, and anti-rheumatics, and that was for about 22% of intentional self-harm hospitalizations. And just note that that category includes anti-inflammatory drugs such as ibuprofen. There's also aspirin and paracetamol, and anti-rheumatics, which is used to treat arthritis. So for that method, there were about 3 times as many hospitalizations among females compared to males. Okay. hop into the next section. So now we're looking, this page is focusing on young people in particular. We've seen young people pop up a lot in those previous visualizations. So we definitely need to take a deeper dive into those younger age groups. And these data includes children and young people aged between 0 and 24, grouped into 3 age ranges, 14 and below, 15 to 19, and 20 to 24 years. For children, especially those age under 10, it's really difficult to determine whether self-inflicted injury was done with the intent to self-harm. So just keep that in mind when looking at this data. So although we did see a concerning increase in the 0 to 14 female group earlier, which I pointed out earlier. Ooh, sorry, let me just, there it is. We can see that this visualization puts it into a little bit more context, that this age group still has the lowest age-specific rate. Nonetheless, there has been a greater than 3-fold increase to the rate of intentional self-harm hospitalizations in females aged 14 and below, from about 19 per 100,000 in 2008 to 2009, up to 70.5 in 2020 to 2021. The 15 to 19 age group had the highest age-specific rate, and we can see that it did jump up a bit over the past 12 months. And if I look at persons, so you see that large jump in females, although it's only a little bit higher than this peak here. If I pop to persons, that jump is largely driven by females. So for males, let me just pop over to males. So intentional self-harm hospitalizations for males also increased, but as we can see here, just not to the same extent as females, with the largest increase being in the 15 to 19 age group. Yeah. So now we're looking at intentional self-harm hospitalizations by Indigenous status and breaking that down by age and sex, and looking at it over time. So overall, intentional self-harm hospitalizations are about 3 times higher among Indigenous Australians compared to non-Indigenous. As with non-Indigenous, the highest rate in Indigenous hospitalizations was in the 15 to 19 age group, and that age group has been up there for a little while. Hospitalizations are also, intentional self-harm hospitalizations are also higher in Indigenous females compared to males. I just hop over to females, particularly in that 15 to 19 age group. And for males, it's the 35 to 39 age group in 2020 to 2021 that stood out. But again, looking at, you can see how much variation there is. So again, just interpret with caution because we'd be looking at much smaller numbers here. Hey, remoteness. So now we're looking at hospitalizations broken down by remoteness. And I'm sure it's not surprising that the very remote areas had higher rates of intentional self-harm hospitalizations, while major cities had the lowest. But if I swap to number, remember I was just looking at rate there, but if I swap to number, swap to number, there we go. Major cities had the highest number of hospitalizations, which was about 66% of all hospitalizations in that year. And that's just because the population was much larger. Okay, so young people aged 15 to 19 had the highest rates of intentional self-harm hospitalizations in every remoteness area, except very remote, where the highest rate was among those aged 20 to 24. So still young people. The 15 to 19 age group in remote areas had the highest rate of hospitalizations overall, followed by the same age group in the outer regional areas. Rates have increased over time in very remote and outer regional areas, but have decreased in inner regional and major cities. So there are some inequalities here. We're almost there with the visualizations. So now we're looking at a breakdown by our primary health network. And this is quite a pretty viz. It's like a butterfly chart. We've got males here on the left, females on the right, with each dot point here representing an age group. And the purple dot is the total age group within a primary health network. I'm not going to go through this in too much details because there is a lot of information in these visualizations, and you can look at the PHNs within each state and territory. And you can also look at a breakdown by looking at numbers and also proportions. So how the proportions work, it's out of within each PHN by sex. So for example, this is 63.81. And then on the males, we have the remaining 36.11. Okay. Just going to have a look at our map here. So this is intentional self-harm hospitalizations by SA3. This is our Esri map. And just to give you a bit of a live demo, you click this button to bring up your legend, just to get an idea of the rates. We have lots of different layers you can choose from. The default layer is SA3 hospitalizations female 20 to 2021. But let's say I wanted to also look at males. So I'm just going to click that there. Put that away. And we're in Belconnen at the moment. So I'm going to type in Belconnen. And I click on Belconnen. And then I get the crude rate for Belconnen in the ACT, which is 278. And then I also get the number of hospitalizations, and I'm looking at females. But because I also added the male layer, I just click this little button here. And then I also get the males. And the more layers I add, the more little extra click-throughs you get. So it's a really cool map. Definitely check it out. It's really interesting, and it gives you a nice, quite a nice big overview of intentional self-harm hospitalizations in Australia. So the last visualization we're going through today is we're looking at a breakdown by socioeconomic areas in Australia. And not surprisingly, the quintile 1, which is the most disadvantaged, has the highest rate of intentional self-harm hospitalizations, while the least disadvantaged group has the lowest. So although it does look like, if we look at this trend over time, that gap has narrowed a bit, there's still ways to go. And this is reflected in much of our research. And if you have a look at our regression model, which we'll go through in a future presentation as well, disadvantage, in this case, it does look like disadvantage is linked to some higher intentional self-harm hospitalizations. And we do know that that social disadvantage does increase your risk of dying by suicide as well. So it's good that we're tracking this, so we can just keep an eye on things. That is it for the visualizations. So I'm going to stop sharing the screen, and then I believe we can go to questions.
Thank you so much, Ros and Chris, for your terrific presentations and really stepping us through the two data sets. It's absolutely amazing the level of detail that we're able to now derive from this data sets, and thank you so much for showing us how to operate those visualizations to take a deeper dive. So we are going to turn to some questions from our audience. So thank you to those who have already submitted their questions. We've got a couple in the chat. Please do pop any other questions in the chat if you do have them. So I'm going to kick off the first question, if I may, and ask both yourself, Chris and Ros. How do we best cross-reference with the new census data so that we can demonstrate a snapshot of distress levels in terms of trying to help find local data for planning? So how do we cross-reference the data sets you've just showed us with the national census data? Or is this possible?
Well, certainly you can cross-reference data from the census, and in some instances, our forward work plan will be doing exactly that, looking at the distribution of relative risk factors across smaller geographies. The way to do that most accurately is to use some of the ABS's statistical geographies. And so that's when Ros was referring to SA3s, for example. That's a layer of geography that the ABS used to classify the entire country. And essentially, the bigger the number, the bigger the area. So it goes from SA1, 2, 3, and 4. Most of what we can do is SA3 and 4. And you can go onto the ABS census website and go into find data, and you can put in your local community, and it will be able to pull that up, and you'll be able to say, show me the SA3 or 4 data at that level. And then you'll be able to pull the same data out of some of those maps that Ros just showed you, so that you can then directly compare, for example, some census characteristics at the same geography as some of the hospitalizations that we showed here.
Thanks so much, Chris. I might pop to Emily's question in the chat, and I think this was for Rosalind, but maybe Chris, you might have an answer too. So Emily would like to know if the intentional self-harm hospitalisation data includes self-harm irrespective of intent.
Well, yes, it does. So that includes non-suicidal self-injury as well as attempted suicide.
Great, thank you. Another question that was posed earlier in the week from one of our delegates on the line: is there evidence that access to means increases the incidence of suicide, in particular among cohorts such as doctors, pharmacists, nurses, veterinarians, etc., and have the suicide rates increased in these cohorts?
Sorry, could I just ask you to repeat the beginning of that, Sarah? That was has access to... Has access to means increased suicide incidence amongst those cohorts? Look, certainly access to means is one of the, or has been one of the most effective suicide prevention interventions. We do know through some of the historical mortality data that we discussed at the last seminar that we saw very large decreases in suicide by firearms following the restrictions that were brought in starting after Hoddle Street, but then flowing through to Port Arthur. Similarly, with restrictions to access to quite potent hypnotic sedatives in the late 60s, early 70s, we saw the poisoning rate from barbiturates fall dramatically. So on that side of the ledger, yes, access to means does play a very important role. But I think it's also, and so we do know from research, we haven't been able to figure out how to tease it out of the data yet in terms of various occupational groups. We've had some ideas, we've started looking at it, but it gets very tricky, again, because of the small numbers and the large number of different occupational groups that there are. We end up with very, very small numbers in each category. We'll keep working on it, though. We do know from research, though, that some of the groups that the questioner mentioned do appear to have higher rates of suicide than the general population. And my colleague Paul Pham, who runs the Defence and Veterans Suicide Unit here in the AIHW, has some really interesting analyses on his part of the AIHW website that teases out the different cohorts of serving and ex-serving personnel and their relative rates of risk. But I think it's important to just emphasise that many of those occupational groups that the questioner mentioned do have other elevated risks associated with their occupations, and so they may be much more higher stress. There may be very high expectations placed upon them by the people who receive their services, their families, their sort of aspirational jobs that people want since they're like very young children. So it can be hard to see a way to remove yourself from that situation if you've spent a long time getting there and people sort of look up to you in that position. And that's an enormous amount of stress, long hours. So I just access to means may well be one element of that equation, but I think there's a lot more going on in those groups.
Definitely. And I think it speaks to the point around the inherent complexity of suicide, that it's never a single risk factor that may or may not lead someone to take their own life. So thank you for that response. We have another question in the chat, this one from Lucas. Is there any ongoing work to measure the quality or accuracy of self-harm diagnoses from the admitted patient and ED data that you've presented today? For example, has it been compared to clinical registers or registries, chart reviews, or any other gold standards? So that's a great question, Lucas. Thank you.
Yeah, absolutely, Lucas. I want to take you back in a time machine 3 years ago when we first started this project, because that has been a problem then and it continues to be a problem today. So I should just clarify for participants today, we have not presented any ED data today. It's all been admitted patients' data. The ED data does not contain any codes on intent. Example I often give is if I was to present to Calvary Hospital here in Belconnen, which is just down the road, and I had a laceration to my forearm, the clinical coding would go, patient presented with laceration to forearm, we sutured it up, and that's the end of the record. So at no point will they capture the intent behind that laceration. There's been efforts in a number of jurisdictions to try and look inside the ED data. New South Wales published some very good analyses on their Department of Health website. There's been some work done in Victoria through Origin, but again, that's been more experimental or research driven than actually trying to systematise that. It's something that we started discussing with our state and territory colleagues about 3 years ago, before the demise of the COAG subcommittee structures. But I rarely get excited about committees, but I can let people know that the interjurisdictional discussion around mental health and suicide data is being reinvigorated at the moment. And that's going to be one of the first things that I take with my team to the jurisdictions to see where we can actually progress that. But that's one part of the answer to the question that Lucas has put there. The other one is on the quality or accuracy of the diagnoses. The quality or accuracy of the diagnoses depends in the admitted patient data, depends almost entirely on self-disclosure. So it doesn't run diagnostic criteria outside of, did you intend to harm yourself? If the answer to that is no, then it gets coded to no. And if the answer is yes, it gets coded to yes. It's slightly different in the ambulance data, in that the paramedics have a bit more latitude to go, well, there was a note and it was a very harmful event. And, the other people at the scene had said that you intended to die. So even though you are now denying that that was your intent, they actually have a separate code for, on the balance of probabilities, this was a suicide attempt, although the person is saying that it was not. So depending on the data set, there's a couple of different approaches.
Right, and it might be a timely reminder just for everyone on the line, just to check in with how you're feeling. We've posted the support services in the chat, and just a gentle reminder to reach out to a friend or a trusted colleague if you need any support during today or after today's session. Another question for you, Chris. Are other states and territories likely to provide monthly attempts and self-harm data in the future?
Sorry, through the ambulance stream.
Yes.
Okay, yeah. We are working with the data provider to get to get Western Australia over the line. There's been some issues with their data system and coding standards mapping to the metadata that the Turning Point use. So we're hoping over this next period of funding that we'll be able to get WA over the line. I'm not quite sure where we're up to with the Northern Territory, although I do know discussions have been had between Turning Point and the Northern Territory. And unfortunately for our colleagues in South Australia, at this stage, the South Australian ambulance services still rely on paper records, and we really do need digitalised records, which are still hand-coded, as in they're read individually by coders to extract that coded information, but they cannot go through duplicate paper records to do that. And having said that, some of this may come down to efficiencies that we're able to find within the coding process to allow us, within the resources that we do have, to bring on board those other jurisdictions.
Yeah, excellent. And thanks for the update. I think it's really important we understand just the amount of work you and your team are doing to try and get all of this data collated and to make sense for everybody. There's another question in the chat, this one from Emily. Chris, are there any plans to explore and map relations between self-harm and risk and protective factors more directly? For example, using bivariate mapping tools. Could this allow for more direct investigations into relations with the census variables? So the question is around mapping between self-harm and risk and protective factors.
Yeah, okay. And so there's well, the short answer to that is yes. The timeline on that is I don't know. I actually have to sit down with the team in the next little while, and we have to plot out what our aspirations are for the next year. And Sarah, as you know, there's while we can't clone each other yet, there is still just a limited number of us. But one thing we published in September last year was some of the regression modelling that we did looking at linked census data to suicide deaths data. We were able to identify some significant interactions there, even when controlling for factors across the model. And we've started to look at how we can make some of those, the concentration of those risk factors and possible protective factors at a geographical level across Australia. We can always map that at a lower level than we can the intentional self-harm, because they're census variables and they include responses from almost everyone within each geography. We're still limited about how far we can go down with the self-harm or the deaths data. But yes, we will be looking at that. And I mean, in some ways, we have risk factors that are modifiable and we have risk factors that are not modifiable. And it's worth having a look at both of those, because even if a risk factor is not modifiable, even in theory, it may change the way you frame your interventions. And I'm thinking here about if you're working with a group of men who are at higher risk, you might frame your interventions in a different way than if you're framing an intervention for a whole population, for example. Similarly, with educational gradient in a community, that might determine, how you structure your intervention. So we will be looking at that. Two other things to just keep in mind is that what we've been able to model to date does not have really key risk factors in it. So it doesn't have lived history of mental ill health. It doesn't have drug and alcohol patterns of use, that kind of thing. It's only what we can get out of the census. So there are some key variables missing there. And if people want to get really geek out on the modelling, there was a extension of that modelling released just today. And that includes the ANU's income variability analysis, looking at absolute quintiles of income and then quintiles of variability within those quintiles. And roughly, the analysis comes out that people with the lowest quintile of income with the highest level of variability have many, many times the relative risk of death by suicide than those people in the highest quintile with the least variability. makes sense when you say it, but the team have been able to go in and actually pull that out of the data and chart it, and you can actually look at the relative risks, and it really shows where we should be concentrating some of our risks. We can ameliorate some of that, you know, we can ameliorate as a community or as a society the levels of variability and relative poverty that people experience. So yeah, we'll be able, I'm hoping people will find that useful.
Thank you so much. That's just a terrific deep dive into, I guess, where the team are progressing, and I guess also highlighting limitations and as I said before, the complexity of this issue. And I really liked the example around how we can use this data for practice in terms of how we structure our programs and services for particular cohorts. I think that's really important, and that's probably why we're doing all of the work that we're doing, and why it's so important that we bring this data to our members and others working in the suicide prevention sector. Another question for you, Chris, and thank you for your patience with all these questions.
No, I've got all afternoon.
Thank you. So how does Australia compare against other countries in terms of collecting and reporting on self-harm and attempt data? Are you able to provide some insights?
Oh, absolutely. I often use parallel to when I got asked this question working in alcohol and drug data in a previous role, and that is I sort of go, oh, C+ could do better, global leader, you know, gold standard. There's a lot of room that we could improve, but keep in mind that capturing this data as well as processing it and presenting it is an enormously expensive process, and Australia's lucky in that we have the resources to be able to invest in those kind of data streams. And it helps us not just in the suicide prevention sector, but in across the health system and across the welfare system. We are very comparable in our capabilities to North America, United States and Canada, UK, Western Europe, New Zealand, and as we sort of get out from those OECD countries towards middle income countries, they have less capacity, and in fact their health and welfare systems aren't as detailed and elaborate, so they've got less contact points with the system for people to have during their daily lives to allow this data to be captured. And then in low income countries, they have very limited ability to capture this kind of information. The other thing to keep in mind is that I think it's fair to say that Australia often comes out in the top of the league tables for a lot of these problems. We do have a lower suicide rate than many other countries, but we're certainly up compared to some others, particularly with drug and alcohol consumption. We are frequently up in the top couple of countries. A lot of that has to do with the fact that people in Australia are much more comfortable with disclosing behaviours such as that we're discussing today, because of a relative lack of stigma and a relative lack of punitive outcomes should they disclose it. So in a lot of countries with strong religious prohibitions on suicide and self-harming behaviour, in fact, some cultures may not even have a word in their language for suicide because it's just so difficult for them to talk about. They surprisingly have much lower rates of suicide, and some theorists will put that down to the inherent religiosity of the population, and I'm sure that has some contribution to that. But I'm quite sure myself that the overarching stigma associated with those behaviours make people more circumspect about disclosing them, and so therefore they sort of give a false reading that's a bit lower.
And I think it's really great that you've touched on the stigma element. And I mean, that certainly comes into play in terms of how we collect data and what's available, because of the nature in which, this suicide prevention and the topic of suicide has emerged in Australia. It's obviously less taboo. So one other question that's come through is around how do we fill gaps in the data that's not available. So for people who attempt suicide and they're not admitted to an ED or don't have an ambulance attend, how do we collect that data moving forward to give us a more meaningful picture?
That is an excellent question, and I've got a few illustrations that I can offer participants around that. Very rightly, the questioner has identified that everything we've discussed today has been administrative data. So if you don't go near a hospital or you don't go near an ambulance, we're not going to capture that event. We're not going to be able to include it in our rates. Just on Friday, just gone, our colleagues at the ABS did publish the most recent national survey on mental health and wellbeing, and that did include the first estimates of suicidal behaviour in the community for a number of years. Honestly, that's one of the only ways that we can get around the use of, we can either construct experiments or and conduct particular bits of research, or we can run population level surveys. The population level surveys do rely on self-report, and so we do have an inherent underreporting there, as was noted earlier, I think, in one of the questions that came through. But that's about as good as we can get. You'll never be able to overcome that deficit. But it's not just the underlying prevalence of these behaviours that doesn't come in contact with the care system that benefits from that approach. There's particular, I'm just thinking again of the earlier questioner talking about particular occupational groups, or a group that's of great concern to us, and that's LGBTQI plus communities and individuals in Australia. We don't have any administrative data that collects the membership of that community or that diverse community, and nor should we. It's not really irrelevant outside of very narrow areas to be asking people questions about their identity in relation to that community. But we do know that there have been surveys conducted, quite good, robust surveys conducted of members of those communities, and tomorrow, I'm going down to Melbourne to talk to researchers at La Trobe University about how we might get access to their data from those surveys, how we can support them to do secondary analysis of their existing data that they have in there, and incorporate that into the National Suicide and Self-Harm Monitoring System. So I'm hoping before the end of this calendar year, we'll have an additional section devoted exclusively to suicidal behaviours in the LGBTQI plus communities and individuals. So that's a long way of saying you basically have to run surveys.
Yeah, and what a challenging space to be working in. But I think, you know, for everybody on the line, how wonderful that yourself and the team are, you know, really progressing this and taking it forward in terms of trying to elicit that data that's missing, which is, you know, absolutely critical in terms of how we respond to suicide in our communities and save lives. So, Chris, that brings us to the end of the questions that our delegates have shared. So thank you for your willingness and your terrific responses to the Q&A session. For anyone, if you do have any follow-up questions, please don't hesitate to reach out to myself and the team at Suicide Prevention Australia. We'd be only too happy to have those questions answered for you. But Chris and Ros, I'd like to thank you sincerely for your terrific presentations today and your deep dive into those two really critical data sets. So thank you so much. And thank you to all of our delegates who joined today and your terrific questions. I do hope that you are able to take away some great information and insights into the data sets that Chris and Ros, you know, have carriage of at AIHW. Moving forward and thinking about what's coming up next, we have another webinar in the series in the not too distant future, which will focus on research. So we do hope that you can join us for that. But in the meantime, I would like to just do a gentle reminder to please reach out for any support should you need it after today's session. And I'm just going to pop the helplines up on the screen for anyone that needs that information. Thank you all so much, and we wish you a great afternoon, and thank you again, Chris and Ros.
Thank you, Sarah. It's been a pleasure.
Thank you.